Okay, so good evening and thank you everybody for joining us for tonight's geriatric assessment update in partnership with St George Hospital. My name is Bertha Harvey and I'm the CPD and Events Manager at Central and Eastern Sydney PHN. Before I begin, I would like to acknowledge the Aboriginal and Torres Strait Islander people of this nation. I acknowledge the traditional custodians and sovereign people of the land across which we work and recognise the continuing connection to land, water and community, and pay respects to elders past, present and emerging. Just a couple of upcoming events which may be of interest. So if you do need to get those review and performance and measuring outcome hours, a lot of these events do have those activity hours attached to that, as well as CPR. So 9th of October at Karilla and Monday 6th of November at our office at Mascot. Cultural awareness training coming up on the 18th of October at Tradies Caringbah. We do have a couple of spots available for that, so please register. And lastly, just a reminder that the stakeholder engagement survey is now available and that closes on the Monday, 9th of October. So you should have received an email with that. Otherwise, you can scan the QR code. So I would now like to hand over to Dr. Caroline Gurgis, who will be talking about health pathways.
Well, hello everyone. As Bertha just mentioned, my name is Dr. Caroline Gurgis. I'll just share my screen here. I'll be one of your facilitators this evening, and I am a GP that works in Kirrawee, as well as a clinical editor for South Eastern Sydney Health Pathways. So I'm here today to talk to you briefly about health pathways. So hopefully all the GPs in the audience are avid users, but in case anyone isn't aware of what health pathways is, I'll just quickly explain. This is also useful as well for our hospital-based colleagues to be aware of, so you can understand the kind of presentations you may be seeing in ED or to your units and gain an understanding of what is possible in the community. Health Pathways is a free web-based portal providing information for point-of-care use in primary care. The pathways are jointly developed by local general practitioners and specialists with the aim of improving the integration of patient care through locally agreed processes and referral information. It aims to assist GPs to provide their patients with the right care in the right place at the right time. If you haven't used Health Pathways before and you wanted to have a look, then here are some QR codes that you can either scan or some web pages that you can click on. Once you go to the page, there's a link to request login information. And again, for our hospital colleagues, this should all be on the intranet at St George Hospital as well. And it could be a good idea for you to peruse it to have a look at what the guidelines around your sphere of work is as well. So the next slide here is examples of what the format of the pathways, a typical pathway looks like. I'll direct your attention first to the image on the left as an example of a health pathway that shows local services, including referral criteria and forms. And this second image on the right is an example of a clinical pathway. It shows how, because these are developed collaboratively between GPs and specialists, we can provide information specific to our area health and what the specialists in this area would really like us to be doing before we refer them. So we aim to make these pathways as localised and as applicable to our local health district as possible. Now, just a bit more focus on our aged care pathways. So this is an example of just some of the live pathways we have on aged care. And I also wanted to flag some exciting news. So over the next 2 years, South Eastern Sydney and Sydney Health Pathways will be undertaking a joint project to update and develop specific pathways to support the assessment and management and referral of older age patients in our region. So currently in South Eastern Sydney, we have 11 pathways, and over the next couple of years, we expect this to become 30. And these pathways should become a comprehensive roadmap to assist GPs to provide optimal care and support for our older adult patients. If you have an interest in becoming a subject matter expert in this domain, or if you have any suggestions to improve these or any other pathways, please get in touch with South Eastern Sydney Health Pathways team. I would like to mention that we aim this to be as collaborative a process as possible with our GPs and subject matter experts. For the GPs here, we are the grassroots of healthcare. If you are seeing something day in, day out that you think, gosh, this is such a grey area, I wish I had some guidance on this, please let us know. Likewise, if you've noticed an issue with the service provision in our area that you're hoping to be addressed, let us know and we'll try and look into it. For our hospital colleagues, if there's an area that you've noticed needs to be clarified or addressed with some of the referrals or presentations you're seeing, new guidelines that need to be accounted for, or a new service you would like to make known, then Health Pathways is the right platform to do that. A group of key stakeholders, including both non-GP specialists and GPs, will meet in November to rationalise which pathways to focus on for next year. So if you've got any suggestions of what you'd like to see on health pathways, then emailing us by October 20 would be great. This is just something that I wanted to flag as well, that you may not know about South Eastern Sydney Health Pathways, that we have a GP colleague referral page. If you're a GP who provides specialised services such as aviation medicine, transgender health, then please feel free to let us know via email or the send feedback link at the bottom of the referral page. And actually, Louise and I were just speaking prior to this about one of the categories that we could add to this is that GPs that do home visits for patients, because this can be a bit of a service provision gap in our area as well. And you'll note as well that there's a new category of anti-D administration, which we hope will help in terms of ED avoidance by providing another alternative pathway for patients to receive this. Lastly, we always welcome feedback. We try and have a robust system for review, and every pathway gets reviewed 3 yearly. And as I mentioned, we're currently reviewing our aged care pathways. If you've used a pathway before and noticed something you'd like to flag with us, please do. You can do this by using the send feedback button on each page, which is demonstrated at the bottom there. If it's something urgent, we can either make changes straight away. Otherwise, we'll take it into account the next time that pathway comes up for review. Here are some contact details. So if there's anything that you wanted to flag with us, please do get in touch. And thank you for your time tonight. I know we're all going to find this talk informative, and I'll hand you over now to Dr. Louise Baird, who's a geriatrician at St George Hospital.
Thanks so much, Caroline. Thank you for inviting me as well. So I'm a geriatrician at St George. I'm St George born and bred. I've been there since I was an intern, about 20 years. I can't see everyone in the audience's names, but hopefully at some point over many years we've corresponded or spoken over the phone. I'm passionate about educating in geriatric medicine. I do a lot of that with medical students and trainees, but I'm very happy to run this teaching today about how GPs can understand what geriatricians do, and when you're referring to us, what a patient might go through. So I've called my talk a Comprehensive Geriatric Assessment. What is it? Who will it benefit, and how will it benefit my patients? And my slides are not moving. I think that was what Caroline was going through before. So first up, I just go through what I plan to get through today. What is a geriatric assessment? Who does it benefit? Who do I refer? What does it involve? What information might I find useful in the referral? And perhaps what should you tell the patient or carer about why they need the appointment? So what is a comprehensive geriatric assessment? Well, it's actually got a Medicare number, which is why it has this fancy sounding title. And the Medicare item number is only available to geriatricians. And it asks us to go through all of the following things, which I'm not going to go through in detail. But essentially, you have 60 minutes with a patient, which is a long time in physician land, really. The patient must be over 65 and referred by a GP. And in that assessment, we're not looking at one specific medical issue. We're often looking at all of their medical issues, all of their functional limitations, any psychological or cognitive issues, and social aspects. So who's caring for the patient? What supports do they have? We look at all of that and then we put it together. We prioritise what needs to be done, and then we have a detailed management plan about how to do it. A comprehensive geriatric assessment can happen with a geriatrician seeing a patient at home, in the clinic, and in the nursing home. And so we offer that service to patients in the St George area. The patients who are seen at home, the referral goes to Calvary Hospital. The patients who are seen in clinics, it goes through the usual outpatients referral. And the patients who are seen in nursing homes, the nursing home refers the patient to us. So the GPs that go to a nursing home can ask the nursing home clinical care manager to organise a referral for us to come out to the nursing home. I'd like to point out that without the Medicare number, the concept of a comprehensive geriatric assessment still happens. It's the model of evaluation that we've always used in hospitals. And it's actually often performed by staff that aren't geriatricians, who are trained or supervised by us. So that might be our nursing home outreach service called the Geriatric Flying Squad. It might be the ACAT teams, or it might be ASSET or the quick response teams who work within St George's Emergency Department to assess older patients over 65. So these are sort of geriatric-led models with assessments by trained allied health staff. So what about all those old people? I thought I probably need to go through a couple of core concepts in geriatric medicine before I talk more about a comprehensive geriatric assessment. And the first concept is that of the difference between biological age and chronological age. So the chronological age is what age you are according to your birth certificate. But your biological age may be higher than that or lower than that. And we may see a 65-year-old who's had a stroke, who's diabetic, who's got heart failure, who's bedbound in a nursing home. And their biological age is much older than 65. We also see entirely robust 95-year-olds who are still driving and living independently in the community. So their biological age may actually be younger than their stated chronological age. And I was watching Indiana Jones with my young children for the first time a few months ago. And there's this great scene that encapsulates that concept really beautifully. So Indiana Jones has just gone and he's saved all the jewels from whatever archaeological dig he's at. And he's on the boat sailing away with the beautiful girl. And she looks at him and he's covered in bruises and sweating and he looks terrible. And she says, "You're not the man you were 10 years ago." And he says, "It's not the years, honey, it's the mileage." And that's exactly what it is in our older patients. It's not the age they are, it's the mileage, it's the comorbidity burden, it's the 12 diseases that they've accumulated and the 15 medications that go with those 12 diseases. That means they're not the person they were before. So those diseases affect function, and that's why perhaps they need supports or more care. It's not just the age. The second concept is frailty. So what makes you frail? Like I said, it's not an age, it's an accumulation of chronic incurable diseases. And what makes you need to go to a nursing home isn't necessarily a lack of help or advanced age. It's because you can't do things for yourself anymore that you used to be independent in. In the hospital and in research, we often measure frailty on a scale. Some of you may have seen this before. This little graphic here is called the clinical frailty scale. And it's sort of overtaken all other frailty scales because it's so beautifully encapsulated by these pictures. And you can see how we go from being very fit and active, running in the Sydney Running Festival on the weekend, to well but not so active, to managing okay but not doing much. And then we start this deterioration of frailty. First, we need a walking stick. Then we're needing a frame. Maybe we move on to needing assistance to use a frame. Then perhaps we're not mobile anymore. Then we become bedbound. And in the end stage of pretty much any disease, we're in bed with someone we love sitting by our bed. It always confuses people why suddenly they've gone from being bedbound to sitting up. It's the family sitting by their bed waiting. So why is frailty important? Why is it sort of important to encapsulate that? Well, we know that a minor illness in a fit older person doesn't affect their function much. There might be, for a short amount of time, a drop in function. They may not cook dinner for themselves because they've got COVID and they're tired and they need a bit of time to recover. But the fit older person gets a minor illness, and by and large, they recover back to the same level of independence that they had before. Someone who's frail, is on their walking frame or perhaps using a walking stick, they have a fairly minor illness, an E. coli UTI, COVID, a little bit of heart failure. And they go from being, say, walking on a walking stick to maybe needing one assist to use a frame while they're acutely unwell. And as their acute illness resolves, their function improves, but maybe not quite back to baseline. So that's the concept of frailty. So those two concepts are sort of core to understanding frail older people. So back to my suggestion as to, who might be a useful person to refer for one of these comprehensive geriatric assessments. Someone whose biological age is older than their chronological age. So the 65-year-old who's, as I've described down here, got a whole constellation of difficult, complex problems: anemic, GI bleeding, AF, anticoagulated and falling. Or the Parkinson's patient who's not able to do what they could before, maybe because of declining cognition, but they also have heart failure, diabetes, polypharmacy. The person who's living alone has no relatives. They're not as good as they were cognitively or functionally. The patient who drinks, who because of that has a series of comorbidities that they're not managing very well because of the alcohol. Maybe it's someone who's got chronic pain, who's functionally in decline because of that pain. So they're the sort of patients that are our core business. Those things lead to this frailty. The other cohort of patients we often see are the ones with decreasing cognition. So I thought I'd start with a bit of a case study. It's what you all see. It's someone I saw recently in my clinic, an 87-year-old woman who lives with her husband in her home. She has increasing frailty and a slow decline in cognition and function with multiple comorbidities. She sees about 6 specialists, all of whom request that she be followed up quite frequently. She's having lots of tests with all these specialists, and there's a lot of tinkering with her medications. And with that degree of follow-up, she's done well. She's been kept out of hospital. However, over time, most of her organs are in some degree of failure. She has 10 medications. We think she's compliant, but she's struggling to get through her activities of daily living, and she's needing more support from her family and more support from services. So when that patient comes to me, I'm thinking, where is this lady heading? And what can I do to help her now in the short term? What can I do to help her in the medium term? And what planning do I need to do for the future? What's the trajectory? So for someone like this lady, and we'll go through her medical conditions in a bit more detail, but it sort of comes down to maybe she'll have some sort of hospital admission with an acute decompensation of a chronic illness. Maybe she'll have a hospital admission with a completely new problem, unanticipated. But that new problem causes some decompensation of her other problems. Maybe she'll end up with an admission because of complications from medication. Maybe she'll have a geriatric syndrome, a fall, some cognitive impairment. Her polypharmacy or her incontinence will start causing trouble. Maybe she'll just go along for some years with gradually decreasing function, but eventually need a nursing home. Maybe she'll have a sudden death at home, or maybe it'll become quite clear that she's in her terminal end stage disease, and eventually she'll need transition, supportive palliative care. And alongside that, it's what does this patient want? You know, she's getting more old in her age, but she's also getting worse in her function. She's maybe aware that she's not as good as she was and that none of her problems are getting any better. Maybe she hopes to not get bad symptoms like pain or not know who she is anymore or not know who her daughter is anymore. I often find patients will say things to me like, I just hope I don't wake up one morning. Maybe she doesn't ever want to go to a nursing home and she's terrified of that. Maybe she doesn't want to burden her children. Then there's often the person who's accompanying her to my clinic. And it's sort of like, what do the family want? Or what can they see? Or what are their concerns? And it might be that they can see a deterioration in function. They can see the impact on the patient, their spouse, the rest of the family. But what they're not often aware of is the extent of the chronic medical problems the patient has. It might be that they take mum or dad to all these specialists and get a sort of tick of she's doing okay. She's really doing okay. The heart's okay. The lungs okay. The kidneys haven't changed much. She's pretty stable. And so they don't understand what future these medical problems have. Perhaps they're not educated on it. Sometimes the family just attribute their declining in function to age rather than what's causing it. They don't understand that link between disease and function. Families, by and large, are aware that their mum or dad might be unwell and may die from something, but they're rarely aware of how we're going to get there. You know, they obviously go, well, mum's 90 and at some point she'll pass away. We get that, but they don't sort of see how it will happen. Families often are really reluctant to talk about nursing homes because the perception in the community is, well, that's where people die. That's where people go to die. If you go to a nursing home, you'll die. And unfairly, the nursing home is sort of blamed as the reason for a patient might die. But the flip side of that is often quite clear early in those discussions with family that some families just aren't ever going to be able to provide round-the-clock care. It might be that they're dislocated all over Sydney, they've got their own jobs, their own caring responsibilities. So as a GP, when you're seeing a lady like this, you know, what do? Do you wait for the inevitable crisis, the admission to hospital? Or is there something else we could do to prepare for that time? And so that's what I think a geriatric assessment can be quite useful. In a nutshell, what I'm doing is trying to optimise function where we can, and where we can't, it's managing the decline. I spend quite a lot of time educating and preparing families for the what if, the what could happen and how we're going to deal with it if it does happen. And I spend a bit of time, if I can, with a patient talking about what their wishes are in the end stages of life. Because most of all, we want to make sure our wishes are met. And it's often unfair for families to have to make these decisions when they don't know what mum or dad wanted, and there's guilt and there's burden. And they often ask for things that they wouldn't want for themselves, but because it's their mother and they're emotionally really distressed that her life could be coming to an end, they ask for. So it's important that we document the patient's wishes for end-of-life care rather than the family's wishes. So putting it together, what do I do in my clinic? The first thing I sort of start with is understanding the patient's life story. Where were they born? If they weren't born in Australia, you know, what brought them to Australia? What was it a job? Was it a marriage? Where did they have their children? What sort of career did they have? If they're long retired, how do they keep busy in retirement? What do they like doing? I often have to spend a bit of time figuring out who's around that patient. You know, is there a spouse? Is there a daughter? Is there stepchildren versus biological children? Is there ex-husband, but they're still involved? You know, who's around and who's doing what? The carer that comes with them, what are their responsibilities? Do they have a job? Are they working full-time? Can they work from home? What supports are they realistically going to be able to provide now and into the future? And if the patient is needing a lot of support already from that carer, how is that affecting the carer? Are they undergoing carer stress? Is there a backup plan if the carer is sick or if the carer is away? Friends and neighbours are often good supports too. So you need to know who's who's doing what. We delve into legal aspects as well. Particularly, it's important to know if there is a formal document that says a patient has an enduring guardian and an enduring power of attorney. And those are needed if the patient loses cognition and loses capacity to make decisions themselves. Many patients don't have these documents. It's just presumed that someone in the family will make these decisions. Legally, a family may not be able to access things like Centrelink and finances to pay for care if they don't have these documents. So it's often really good early on to make sure if someone's developing cognitive impairment, they have these legal documents in place. I'll also ask if the patient's ever made an advanced care directive. I would say it's very rare. 1% of my patients, maybe. And if they do have one, what does it say? Often it's good to find out if there's any concerns by relatives or perhaps yourselves or other staff that have met the patient over the years, whether there's concerns of neglect or abuse. And that can be financial abuse, it can be physical abuse, it can be emotional, sort of coercive abuse. And things like alcohol or illicit substances or dependency comes into that as well. The next thing is, what is the patient's function? So I'm going through the basic, you know, can they toilet and shower themselves? Are they mobile independently? How are they eating? How are they shopping? How are they getting places? Are they still driving? If not, can they use public transport? If not, are they going anywhere? Because some patients don't go anywhere, they're housebound. Who's doing the finances? Are they still using the bank? Are they internet banking? How do they contact people? Are they savvy on a mobile phone? Can they use a smartphone? Can they text? Do they email? Do they Facebook? If they need help, is there an emergency call, a vital call to get them help if they live alone? How are they dispensing their medications? Is it in packets all over the kitchen, half of them out of date? Could they get those wrong? Or are they using a Webster pack? If they're at risk of falling and they live home alone, who can access the house? You know, is the daughter with the spare set of keys across the other side of Sydney, or is it the next door neighbour? Or if they set up one of those lock boxes out the front so emergency services can get in? Do they have equipment? Do they have services or approvals for services? And what allied health staff do they go to? Do they see a physio or podiatrist? And are there safety concerns? And that may be around leaving a stove on or the locks, losing keys, losing wallet. And I guess the other thing is, what is meaningful for this patient? How do they want to spend their time? For some, it's going to the Sydney Symp, for others, it's the art gallery. Some want to spend time with the grandchildren, go on holidays. But what's meaningful for them? Do they do any physical activity? Do they do anything cognitively stimulating? It's very hard for older people to take up a new hobby. So you're better off investing time in understanding what they do like and fostering a way for them to continue that as their functional cognition declines. What are their chronic medical issues? Do they cause symptoms? I mean, I often see a lot of patients come to my clinic with pages of diagnoses listed. And when you ask the patient about symptoms, they don't have as many as you'd expect. But the really difficult ones are things like pain, loneliness, insomnia, tiredness, swollen legs. And if they have symptoms, dyspnea, angina, peripheral neuropathy, those sort of things, how severe are they and what impact do they have on their daily living? What does it stop them doing? Do they have an end-stage disease plan? So for someone with chronic renal failure, are they on a dialysis or non-dialysis pathway? For someone with congestive cardiac failure, are they likely to be admitted to hospital for intravenous Lasix, or are they on a symptom control palliative pathway at home? It's really important that I'm corresponding with anyone else actively involved with the patient, because there can be 10 specialists involved. And do all their background diseases, do they cause geriatric syndromes? Do they cause falls, poor mobility, weight loss, sarcopenia, loss of muscle, osteoporosis, incontinence, dementia, delirium, pain, hearing, vision problems? Are they at risk of things like pressure sores? And then I'm sure you're all aware of polypharmacy because you're all writing these scripts. Patients, I find, have very little knowledge of these medications, and wouldn't know what's making them feel better and what's not. So I often, with the families and with the patient, sort of look at the medications and write 2 columns. And I go, these are the medications that are making you feel better, you know, the symptom relieving medications. And these are the medications that aren't relieving any symptoms, but are aiming to reduce long-term problems. And they're things like your anticoagulants, antiplatelet agents, blood pressure medications, chemotherapy, osteoporosis stuff, statins. And for the ones that aren't relieving any symptoms, it's a balancing act about whether they're still appropriate for, you know, the very frail patient who's wheeled in on a wheelchair. So are they still needed? So things like a patient might have lost 20 kilos in the last 4 years. Perhaps their blood pressure isn't as high as it was. Perhaps their diabetic control isn't as poor as it was. And some deprescribing can begin to happen. I spend a lot of time figuring out if they want to take tablets or not, if they are taking them correctly. Is there a risk of overdose? So in patients who've got these Webster packs that are full of cardiac and diabetic medications, taking 2 or 3 days in a row as an accidental overdose can be fatal. Or for those who have depression, an intentional overdose can be fatal. So is the Webster pack safe? Is it a risk of overdose? Can we consolidate? Can we have combination medications, or can we just stop some of the medications? And if I choose to discuss that with the family and with patient and we decide to stop things, who do I need to inform that perhaps prescribe that in the first place? There are medications that make a geriatrician shudder. And these are largely what we call medications that are in the Beers criteria, which sounds like it's related to alcohol. It's not. It's the Beers criteria is a group of medications that I think was started by the American Geriatric Society. And they're medications that are considered potentially inappropriate, particularly in older people or with people with certain diseases or syndromes. And they're things like benzodiazepines, anticholinergic medications, antipsychotic medications, what else is there? Multiple combinations of medications like Parkinson's medications that can give you psychotic features. We also look at whether there's potentially inappropriate interactions or whether you've started a drug cascade where you've started one drug to counteract the side effects of another drug and then another drug to counteract the side effects of that drug. And And we also look at whether medications need to be, the dose should be adjusted because of perhaps renal failure or liver impairment. So after I've done all of that, we're often quite exhausted, but we need to move on. We need to keep going. And the next thing is the cognition. First of all, it's what's their brain injury profile over the years. Have they had head injuries, strokes? Have they had injury from alcohol? Is there a family history of dementia? What education level did they achieve? Were they a PhD, professor, or were, you know, had very little formal education because of being dislocated perhaps during the war in Europe? And, you know, their formal education may only be a few years and it be in another language. Have they had particular mental health issues like depression? And then we go through the specific cognitive symptoms that a patient with early dementia may present with. The typical memory problems, the typical language, orientation, executive function, that's the ability to organise and judge and plan. Are there behaviour changes? Is there personality change? Is there a language problem, speech problem? And how do those cognitive deficits in all those different domains impact on someone's ability to function and to mitigate harm? Then I do a bit of a top-to-toe physical examination, and it really starts in the waiting room. You know, as the person stands up, do they need anyone to help? Do they need a mobility aid? How difficult is it for them to get out of a chair? And how do they walk into the room? How well are they groomed? You know, often that's my first sense that someone may be not functioning how they used to. So starting top to toe, we do some cognitive tests, and you'll see in many letters from geriatricians some screening tests listed there, the Mini-Mental, the RUDAS, the MOCA, the ACE. And often those, which one we choose is largely dependent on the patient's language or what we suspect is the type of dementia, because different tests look for different dementias better. But beyond that, I'm also like, when I'm taking the history, how much are they contributing to it versus the daughter sitting there? Do they seem to be able to react? I'm often trying to make a few jokes during the clinic just to see if I can get some joy, some laughter, some emotional response, to see, you know, if they're very depressed, if they're very flat, you know, that may be something I need to look at as well. Obviously, we assess a little bit of their vision and hearing. Cardiorespiratory exam, most of my patients have AF and a murmur, and that may affect their postural blood pressures. And we do a postural blood pressure. We make them stand up for 3 minutes and see if their blood pressure drops. And if they're breathless walking into the room, I'll often do SATs. I often find people with SATs of 90 who are quite breathless on minimal exertion. I'm interested in their abdomen mainly to see if they've lost weight and to see if there's scars. And it's always a reminder to me to talk about bowel management, because constipation is such an issue for older people. I can formally assess their mobility with some standardized tests like the 6-meter walk test. And while I'm doing that, I'm often looking for neurological abnormalities. So the tremor with Parkinson's, the rigidity, the bradykinesia. I'm looking at whether they've got a stoop back from osteoporotic crush fractures. Continence is a big part of the assessment too. And I always get down to the feet, because it's really interesting to see whether the patients can take off their own socks and shoes and what's under them, because they're often not looked at. And there's often poor foot care and fungal infections. And there's huge, often quite severely deformed feet from bunions and those sort of things. So once I've gathered all of that information, which is a lot, and it's exhausting for the families to go through, my job is to work out, is there a new diagnosis I need to make? And it's often dementia, it's often the case. And to give some time for the patient and family to process that, to give them some education about what that diagnosis is. I often will give families a whole lot of printed information from, say, Dementia Australia to take home with them to read, and then bring them back at the next appointment to ask questions about the papers, because I can't give a 1-hour lecture on dementia to a family who's just been told they've got dementia. I run through the basics of why I think that they've got that and give them a pathway to learn more. I then often spend a bit of time prioritising and prognosticating. So is this person rapidly deteriorating and I need to organise everything now, or have we got a bit of time to do it? And if one disease is likely to deteriorate, what are we going to do when that happens? What's the plan? And how are the family going to action that plan? And I'll spend a bit of time then writing a big letter with those recommendations and follow up, and communicate that to you and everyone else involved in that patient. Oftentimes I'm referring through My Aged Care for an ACAT assessment to provide that patient with services, with support. That may involve referral to things like continence nurses, physios, occupational therapists as well. And I find that my to-do list after a clinic appointment with a comprehensive geriatric assessment, it may take 6 months to get through. Like if I ask for a bone density because I'm worried that they're falling and maybe they've got osteoporosis, and I ask for an MRI brain, and I ask for an ACAT assessment, a physio and an OT, and a continence review, that's a lot for a family to get through. I mean, you really can't do more than 1 or 2 in a month of those things. So it's sort of prioritising that and organising what I can from that in a sort of priority list for the family to work through. And many families are extraordinary, and they come back in 3 months and they've covered the whole list. So back to my case in a bit more detail. So my 87-year-old who lives with her husband, she has increasing frailty and slow decline in function and cognition. Remember, she sees the 6 specialists. She has all these tests, which have by and large kept her out of hospital. She has 10 medications and she's compliant. She's getting some support. Her husband is older but more robust. He still drives. He supports her with the shopping, the finances. He supervises her showers and her medications. And her 3 daughters all live locally. They all help. There's a level 2 package, which isn't much in hours. It's maybe 4 or 6 hours a week. And that's for cleaning, podiatry and social support. They use some of the package money for equipment to put in rails. They've bought a vital call. And there's 2 different mobility aids for different settings. There's no backup plan that they knew about or had planned if the husband was unwell. The daughters suppose they will just help more. There's no advanced care directive. And the children do have the legal documents for enduring power of attorney and guardianship. So I alluded to this lady having a lot of comorbidities. They're all listed there, and they're classic: the hypertension, the diabetes, the cured breast cancer, hyperthyroidism, cardiac disease, starting with AF, but surprisingly okay function. Syncopes with Holters showing bradycardia. Extensive investigations of blood pressure. Crush fractures, bad spine from that, and arthritis, a bit of GORD, a bit of renal impairment. She's due a cataract operation, and one of her big complaints is that she's had a dry mouth. Surprisingly for that list, she's not on more. So my polypharmacy that I divide into what's making her feel better and what's stopping disease progression and preventing some diseases. And it's actually surprising when you divide out these medications how few are actually making patients feel better. But that's common. What about the geriatric syndromes? Well, she's got cognitive impairment. She's forgetful. She's disorientated. She has poor executive function, so she can't organise anything. Everyone else is doing that for her. And I observed a lot of interactions between the patient and her daughter. And she was quite rigid in her thinking. She's a little bit argumentative. And she was less able to speak English to the level she used to be able to. She couldn't find the words, and she'd defer to her original language. She'd had falls. She had osteoporosis, which wasn't surprising when she'd had courses of prednisone and tamoxifen. She had urinary incontinence and had frequent UTIs and frequent delirium with those UTIs. Pain with no regular analgesia and no physio or physical therapy for that. So this very comorbid lady looked meticulous. She didn't weigh much, 48 kilos. She was engaged in the history, but the history she would tell me was completely uninformative. She'd go off on tangents, and then the daughter would try and bring her back on track, and that would start this argument. She had a postural drop. She had poor vision, poor hearing. The cognitive screening test we use in patients who don't have English as a first language, the RUDAS, was pretty impaired. That's moderately impaired. Getting up out of the chair, she had to use her hands to push off. But once up, she mobilised quite briskly, almost impulsively, and she was a little bit unsteady. So she's a falls risk. She had a heart murmur, but she wasn't in heart failure. She was very dry in her mouth and no scars in her abdomen. She was wearing a pad. The pad was already wet. And her lower limbs showed dry skin, lots of scars from skin tears or ulcers, chronic venous insufficiency, but no active edema. Arthritis in her feet, bunions, she couldn't reach her feet, and she had impaired sensation. So she had a peripheral neuropathy. So where to go? I made a new diagnosis of dementia, and so that involved education, discussing how it's going to progress and what might impact that, often things like illness, acute illness, or episodes of delirium. I talked about how that dementia is affecting her behaviour and why she's become argumentative. I talked about how her dementia might be affecting her mobility. We talked about a delirium plan. If mum got much more confused very acutely, what to do about it. We talked about changing the supports or increasing the support. So the husband was doing the bulk of the work. Carers came in twice a week, but they didn't really spend much time with her. They were doing things around the house. And the daughters came and did the shopping and took her to appointments. But by and large, she actually wasn't doing much each day. So we talked about other options, whether there was community bus trips or dementia daycare. We talked about medications in the setting of vascular dementia. Aside from that, we talked about her other geriatric syndromes, her falls, her pain. What can we do for those? So often I suggest exercise programs tailored to frail, older, cognitively impaired people, like the Stepping On program. It's run in community centres all around our area. It's a one-term program where you're taught some exercises and expected to learn those and continue them long-term. For pain, we talked about analgesia. We talked about mobility, what to do if she has a fall and what might lead to falls. For her urinary incontinence, we talked about the risks of infection and delirium, and in making sure her personal care was adequately managed. I often then get a continence nurse to look at whether she's using the right continence products, whether she's understanding the impact of constipation on her continence. We looked at increased services and support and what to do, how to navigate the healthcare system. What's her overall prognosis? I'm not sure that I know. It's probably unlikely to be 5 years. She's frail. She's got multiple organs failing. It could be a slow deterioration from her mobility changing or her organs failing. It could be a slow progression of her dementia to the end stage bedbound dementia aspiration pathway. But it could be much shorter than that. One bad sepsis and her heart and her renal failure may deteriorate. It might be one bad delirium and she's unable to go home again. It might be one bad fall. She has a subdural, a hip fracture, a pelvic fracture, and that may be enough to impact her mobility that she couldn't be at home. So again, if those things happen, what's our advanced care plan? What's our, has she made an advanced care directive? If I get through all of that in an hour, I'm doing well. I try to. Sometimes we don't get through all of it. But the next thing is you've got to follow up. So that's overwhelming for a patient and family, and they won't think of the 20 things they wanted to tell you. So I tend to often copy the patient's family into, or the patient, into the letter so that they can see what we talked about and what we planned and what I'd organised, what I'd asked them to do. The families always know how to contact me in the event that they end up in hospital. It might be in a different ED or a private hospital. I talk about, trying to think what I meant by that third one. I think I talked about if a patient ends up in a hospital under another specialty, like maybe having an emergency admission for a bowel obstruction, which I don't typically look after, I can still support the family and the patient in hospital. So how to contact me and sort that one through. And where there's a spouse who's also frail, I often suggest it's a good thing that I see both as patients, if that's appropriate, just so I get a real sense of who's the sicker one and what are we going to do when they become sick, because often they're codependent. If I don't understand the medical needs of the second person, I struggle to understand how they're going to manage in any given scenario. For instance, if someone needs assistance to mobilise after a pelvic fracture and I don't know if the husband's got a problematic back, it's difficult for me to work on a discharge plan. So I might sort of stop there. I hope I've gone through what my learning outcomes were. I did have a couple of other slides, which I might leave up the end, and I'm hoping we'll get into this website so you have a better idea of how to contact us. And that's how to get someone into a clinic urgently, which is ringing through our office. For urgent nursing home reviews, we have the flying squad that go out to nursing homes. For hospital-based, hospital in the home, so IV antibiotics, eye and arm monitoring, IV Lasix, we have a different service. We have a service called the Quick Response Team who see patients in emergency who have had things like falls, but they're also happy to see patients in the community who don't need to come to ED, who might have a mild delirium from a UTI, but the family need education and advice. And for those patients needing a home geriatrician review because they can't make it to clinic, maybe they're needing too much assistance to get there or they're too behavioural, our geriatricians that work in our department also work at Calvary and they see patients in that capacity. So I might stop sharing so I can see the questions. So the first question was, if someone is very frail, would you stop the warfarin for AF or if unable to tolerate a NOAC? Hard question to answer. And every patient, it comes down to what is the benefit of that. So for a cognitively normal patient living at home who's by and large living, independent in toileting and mobility, not hugely impaired cognitively, if that patient stroked, it would be a terrible outcome and it would affect their function. Whereas if I've got a patient who's bedbound, who's falling a lot, whose heart is failing and they're not expected to live 12 or 18 months, there's more risks than benefit in that setting for anticoagulation. But every patient, it's difficult and it's a discussion. There's certainly many I've stopped anticoagulation and they've gone and got, an emboli, in their perineal artery or something, or they've gone and got an ischemic gut the next day, and they've had a difficult end for stopping the warfarin. So it's always a difficult discussion. You've got to balance the risks and the benefits. Second question. I've had no success in referring to a continence nurse as a GP. Last time I was told they were only available in the Sutherland, not St George, or not available. So you have to, the only way I can get a continence nurse is to refer via My Aged Care. So that's going through the My Aged Care portal, and specifically you have to enter all your demographic sort of information as well as the patient's demographic information, and then requesting a continence nurse review. So I can't ring up a continence nurse. The only way I can do it is through My Aged Care. Do we need referrals for geriatric assessment home visits is the next question. Yes, we do. If a geriatrician sees the patient, we actually have 2 advanced trainee registrars who go out and do home visits in the community as well. And they don't need a referral, but because they're supervised by a geriatrician who may well need to go out with the registrar to supervise them appropriately, it's useful if we do have a referral.
Louise, we're just wondering as well, can you cover what tests or assessments a GP should conduct before referring a patient to you, or what information you want included specifically? You mentioned, if you're referring a patient for an MRI brain, it may take them some months to get it done. And quite often we'll do a CT brain beforehand, but is there anything else specifically aside from a standard dementia screen that you would like, or what do you consider a standard dementia screen?
Look, I don't mind whether a patient has these tests before they see me or not. It is useful. It makes the diagnostic process faster if they have. By and large, a CT brain gives me most of the information I need for a frail older person. For a younger person who's just a cognitive issue, I will often do more neuroimaging, so an MRI brain is useful in that setting. But the frail 90-year-old who's going to have trouble getting through an MRI, or they've got, a pacemaker or mobility issues, I would never send them for an MRI. I would rely on the CT brain. It gives me enough information. And often I've got these wonderful secretaries who sit there and go through all if I don't get information on the referral about neuroimaging, my secretaries will sit there and go through all the different radiology places that we've got passwords to and dig up their neuroimaging from before so that we can avoid, because if they're frail, these patients, it's hard to get them through tests. So we try and not repeat tests or do an MRI in addition to a CT. Just one's fine. We have a new test in the hospital for dementia, which is a PET scan that gives us information about different types of dementias in the brain. It's new to us. We're still learning how to use it, but by and large, I think it'll be in fairly early cognitive impairment to help us ascertain whether it's Alzheimer's or one of the other dementias. And that's because there may be some Alzheimer's therapies on the horizon, and I suspect to give those, we will need, a biomarker evidence that a patient has Alzheimer's as opposed to vascular dementia. And the biomarker may well be the PET scan. So I've probably sent 5 or 6 patients for a PET scan. I'm still learning who to refer and what benefit there is to doing it. But that's another test that we're starting to order. Again, because it involves so much preparation, I wouldn't put a very frail, 90-year-old who's cognitively impaired through that test. It would be more for the younger cohort who are more functional. And it means people who are perhaps still working or still driving, we're making a really accurate diagnosis is important.
That's great. Very interesting to watch this space. All right, I think they're all the questions we've got at the moment.
Yeah, if anybody had any other questions that they wanted covered, you can quickly pop them in. Otherwise, I will start. Oh, hold on, we've just got a question come through. So what sort of assessments for fall risk is done, especially if there is cognitive impairment?
Yeah, so I mean, in the clinic space, I'm doing basics. Can they sit to stand without using their hands? So, put their hands on their chest. Can they stand up just using their legs? And then get them to do a 6-metre walk test. So walking, 3 metres this way, 3 metres back, and how fast they can do that, and what mobility aids they need. Physiotherapists have a lot more tests and assessments that they use. And they're by and large used if they're going to do a program of rehab to gauge improvement. But by and large, you know, if you're seeing someone who's unsteady, who's grabbing onto furniture, who's looking like they could fall over, they're the patients that we're worried about falling. Or if they've got a history of falls. It's hard to turn a faller into a non-faller. You may reduce the number of falls, but it's hard to stop them falling.
Great. Thank you very much. And I think that is our last question. So I would like to thank our speaker tonight, Associate Professor Baird, and also Dr. Caroline Gurgis for her Healthways presentation and facilitating the questions tonight. Thank you, everybody else, for attending. And as soon as we end the webinar, you'll see the evaluation pop up on your screens. Thank you very much, everybody, and good night.